It's my pleasure to introduce our next speaker, Dan Kang, who will be giving us a talk on revision strategies for failed cervical total disc arthroplasty.
All right. Good morning. Thank you so much. Thank you to UCSF Spine. Thank you to the program chairs, Lionel, Lee, Kyle. Thank you so much. Also to our distinguished professors and honor professors. It's been a really great meeting. I have no relevant financial disclosures. I'm going to show a slide here. This is me and Lionel last year, and I just updated this, me and Jamal. There's a reminder that we get another updated picture, because it's always good to reconnect here in Hawaii. It's a really beautiful island, beautiful people. So thank you. So here's our agenda. That's what I'm going to talk about. So there's a picture of a unicorn. This is my daughter. Her fourth birthday just a few months ago was a unicorn theme. Really piqued my ears when James the other day talked about cervical laminoplasty in the unicorn patient. And I think we certainly look for that in our cervical disc replacement patients. They're out there, but it's not that common. You know, the patient with the soft acute disc herniation, really no osteophytes, really mild spondylosis, and minimal disc height loss. And typically want some good or normal bone quality. And why is that? Because these patients are going to do great. But we know from the FDA trials that there were significant exclusion criteria from what they studied for both 1 level and 2 level patients. As you can see here, there's not for you to read. I know it's hard to see, but you can see it's almost like a third of the length of the inclusion criteria versus the exclusion criteria. So what does that mean? Probably in the last decade, there's been, as we know from Dr. Sun's talk, there's been an increase in cervical disc replacements in this country. Seems like in China, it's going down for various reasons. But I think there's been some physician-directed use, meaning that there's some patients we think confers a benefit by doing a cervical disc arthroplasty and motion preservation, but we don't know who those patients that may not have a good or optimal outcome. I think one point I took away from the talk on Thursday was that really we should be using this to preserve motion, not to restore motion. And I think there's some relative contraindications from what we saw on the exclusion criteria, but like Dr. Sun talked, this greater than 50% height loss, I think you got to have less than 20% height loss and maintained motion. I think I took that away from the talk, and I think we're putting disc replacements in these patients, and maybe that's not really performing the way we expect them to. There's also extended indication. There's numerous retrospective studies on hybrid constructs, adjacent to a fusion, greater than 2 levels. We see this a lot. Patients who are really either market forces or patient demands. And then there's this study that looked at prior surgery at a planned surgical level for disc arthroplasty. They had 15 patients, and they had some patients where they reversed it for a pseudoarthrosis. So we're talking about patients that, have less than, don't have any disc base, and now you're trying to recreate motion, which I don't think is a great idea. And they agreed in that study as well. So what's the scope of the problem? How many of these revisions are happening out there? So what do? I go ask open evidence. We use AI, and this is what we found. It said the revision rate's about 1 to 8%. It's pretty wide variation. This is at 5 and 10-year follow-up. It really depends on the population, the study design. I did my own search at PubMed. It took me several hours. That OpenAI thing took like 30 seconds. And these are all the articles I could find, different meta-analyses. And I'm going to go pretty quick through this for the sake of time, but also because you can just go look on AI. So I'll just hit some high points here. The study from 2018. The main point of this is that there's a 20% increase per year over this decade that they looked at. The most interesting thing was this table. You can see down here that about 75 patients in that 10-year period, ages 80 or greater than 85, had cervical disc arthroplasty, which is a commercial database out of ProDiver. But, you see those patients that are physiologically young, but the conferred benefit of adjacent segment disease may not benefit them. This is a follow-on study. It was about a 5-year window that pushed past that, and they said it leveled out. It's a 15% increase per year in the windows that were after 2015. We don't have the next 5 years after this, but also I think that, the single-level disc replacement, there may be a reason for this, is because right around that time is when the 2-level indication came out, right? So for insurance approval. So maybe there's less single levels, but, what's better than a single-level cervical disc? A 2-level cervical disc. So this is another study from 2025, so more recent, just about 6 months ago. This was exceedingly low. It's 1.2%, but what's interesting is this ProDiver study. The rate from the Ramaswamy that I just presented, that was 2.4%. It's the same time period, but they presented a 1.2% rate, which was lower. This is a study out of Columbia, same thing. The main thing out of this study was that the main reason was cervical spondylosis or recurrent or persistent symptoms. And most commonly was the anterior-based approach, but they also used anterior and posterior approaches. Another systematic review out of Columbia. This looked at all the IDE trials, about a 4% rate that they saw. Again, anterior approaches were the most common. This is a study that I think gets a little bit looked over. There's a retrospective analysis out of Sweden. It's a 10-year review of their own patients. Interestingly, they had a 94% follow-up rate. So minimum 5-year follow-up, about 700 patients. But this number that they found in their own patients was that there was an 11% risk of revision at the index level. And this is compared to 15% in their ACDF. This is a significant difference. And the significant odds of having a revision if you did cervical disc versus ACDF. And there was no change in their reoperation for adjacent segment disease between arthroplasty and fusion. So that's just kind of the scope of the problem. It's out there. I think it's increasing because of increased use of cervical disc, but also the fact that our indications may not be as tight as what was looked at in the IDE trials. Next is, what is a failed cervical disc? So how do we define that? So I think we can all kind of know what a failed surgery is someone who's having continued pain, either neurologic symptoms, neck pain, arm pain. And the way I've kind of looked at it, just in the few patients that I've been able to take care of, is that there's either a problem with the bone device interface or the device, its function, or the actual segment that you're looking at in terms of stability. This is a study out of Rush. They tried to kind of categorize and look at the different types of failure modes, as well as kind of provide an algorithm. They also found kind of a 5% rate in their own patients, and then they did their own systematic review. The most common reason is because of recurrent pain, recurrent neurologic symptoms requiring some kind of decompression. And this is all just for reference. You can look at this. A little overwhelming. When I looked at it, looking at the 6 primary failure types, and I'll kind of go over how I kind of split it up. And then this is their algorithm. Again, if you want to go reference this article, I think if you go down this tree here, you'll find kind of the right idea of what you need to do. But to me, it was also just a little bit kind of overwhelming. So for me, the way I just kind of look at it is, first I look at whether they're still having neurologic symptoms or pain. Is either persistent or recurrent. You got to get a nice history from the patient. Sometimes it's hard. They've had something like a year ago. They can't remember exactly, but they're having some kind of something where they need a decompression. They need something where they need their neural elements opened up or stabilized. And the next is the bone device interface. So I like to look at it, just kind of taking it from our total joint replacement surgeon kind of failures from our colleagues on the arthroplasty side. It's either well fixed, loose, or there's bone loss. And that bone loss can vary, and then whether that's septic or aseptic. And then you have to look at implant position and size. So how is it interfacing with the bone? Because obviously we know that if you're undersized, that leads to a higher rate of subsidence. And then finally, just look at the device, whether it's functioning well or the way it's intended to, or it's malfunctioning. And that includes device failures, which is luckily not that common, but it can happen. And then next is just look at the motion segment. Is it stable or unstable? The total opposite is autofuse, which we heard about heterotopic ossification, and that's the ultimate stability. You've essentially got a fusion. So just going through some of those subtypes. So there's just a patient that had a ProDisc C, comes back a few months later, has some worsened neck pain, arm pain. And I'll have some cases later for if we have time, but you can see that maybe this is reasonably placed. And you can see here at 3 months, there's a little bit of coronal deformity there. And if you look at the lateral, you can see that it's subsided. So that's the main reason for his symptoms and pain. Ended up doing a revision. So as an active duty soldier, he's about 1.5 years out. You can see here that he came to clinic saying, my neck keeps hurting. I had a surgery out when I was in New Orleans, and he ended up having this, and then he had some segmental instability. He didn't want any more surgery. He got out of the military. And so we just followed him up, and he didn't want any additional work done. We've seen this in a prior talk, motion loss, heterotopic ossification. Here's another one. This is kind of both. You have some subsidence of the superior portion of the device, and then leading to heterotopic ossification. So let's talk about some clinical dilemmas. I think the main thing that we know that faces us when we see a patient in clinic who has a cervical disc replacement and comes in with pain is, okay, what kind of device do they have? How am I going to get imaging and diagnostic workup on this patient? They usually come in with an MRI, but depending on their device, it's completely useless, and you're kind of left back to square one, right? So I think the utility depends on the device, depends on the MRI that they had based on the size, the strength of the MRI, and whether a specific metal artifact reduction sequence or MAR sequence was requested. Sometimes those aren't even that helpful. And then I think it can be helpful for the adjacent segment. If you, based on their history, think that it's something that's recurrent that could be at an adjacent segment. This is a nice article out of Neurosurgery Review, but the main thing is that if a device has cobalt chromium in it, it's going to be totally blacked out by the artifact, or stainless steel. Favorable are these devices which have titanium. So understanding which device is in the patient and understanding what those look like for some of our trainees will help you determine the next step and at least understand that the MRI may not be helpful at all, except for looking for the adjacent segment, which I think most of us don't get. Other things that we get, CT myelogram, that has its own host of complications, but that is the next best imaging study. And then we can do selective nerve root blocks, medial branch blocks. We know these are some diagnostic things that don't have great specificity or sometimes sensitivity. Same with EMG nerve conduction studies. We know that from Dr. Rue that EMGs in 20% of the cases, even if they have an active radiculopathy, won't pick it up on the electrodiagnostic studies. And then quickly, I won't go too much into these specific strategies. I think ultimately it has to depend on the patient. You saw that tree from the study out of Rush. If I could just go back here to the posterior base, I think, if someone's having recurrent symptoms, you can do a laminoforaminite. Interestingly, there's some discussion about posterior only. I think that's really typically in conjunction with some type of decompression, but only if someone had some really large amount of segmental instability that you would really want to do that without adding in some kind of decompression on top of that. Something that's been described that Dr. Rue and some of our colleagues out of Asia talk about is anterior foraminotomy. As we know, that can be very useful in certain motion preservation kind of strategies. But when you're talking about our cervical disc replacements, you're kind of relying on those uncinate joints. So what the long-term consequences of that are still kind of unclear. You can remove the device and revise it. If you feel like it's the right patient and they have enough bone stock that they could function well, and that's usually the non-keeled devices that you're looking to do that in. And then these are your other strategies, which I think most people are well versed in being able to do that. So ultimately, our take-home points, there's certainly been an increase in the utilization of cervical disc replacement, both in the single level and two level. The CDA failure rates and ultimately needing revision, probably around 4 or 5%. It ranges up to double digits in some studies out of Sweden. But it's probably going to see more, especially as our disc replacements move down the line. We get longer term follow-up. So just as we've seen in our arthroplasty colleagues in orthopedics, everybody getting disc, and those are patients who are typically getting them in their 50s and 60s. We're trying to focus these on patients who are 30s and 40s, maybe 50s. They're going to live a lot longer and ultimately potentially need revisions. I think for any case that we do in spine surgery, there's obviously just a foundational principle of having good patient selection and surgical technique, but there's probably less room and forgiveness when doing a cervical disc replacement that you can get away with, when you do an ACDF. And finally, we know that there's some dilemmas in, decision making. And I think because not all of us, no one has like just a primary revision cervical disc replacement clinic, right? I mean, there's some places that do just revision joint replacements. And so, each of us going to see 1 or 2, maybe some places are really busy, 10 of these a year that are coming in to see you. So I think the more we share, the more we can understand about how best to treat these patients as, we expand our indications as well. So I'll go through some quick cases. We got about 5 minutes left. So this is my first case. This patient came to me after they had surgery, but this is some of their pre-op imaging. You can see here that they have some disc degeneration, kind of more at the upper levels, 3, 4, 4, 5. He has decent motion up top when he does flexion extension, and he comes in with this MRI. He has myelopathic and radiculopathy symptoms. He has some component of congenital stenosis. And you can see here that he's got some cord flattening. And so ultimately you see this, and then the next slide, which I show here, is you can see that This is sort of the mid body of C4. You can see there's this black line that's sort of this double layer that, kind of indicates maybe just this isn't a soft disc or some osteophytes. He actually had a pre-op CT scan. This was done before his surgery, most likely for sizing, but not quite sure when the surgeon that looked at this and ultimately decided that maybe cervical disc replacement was the right idea. I would say that if we saw this in most of our clinics, we would suggest that maybe a fusion or something even more bigger than just the ACDF, potentially corpectomy based on the retrovertebral compression would be the better option. Ultimately, he had a 2-level disc replacement. This is initial post-op x-rays. About 3 weeks later, he ultimately had some worsening deformity, worsening pain, continued myelopathic symptoms. And you see on flexion extension, you can see kind of the lift off of the back of the end plate on the superior portion of C3. And probably when you look at it, it's just a little bit undersized too. So just looking at it now, we can kind of criticize it a little bit, but those are just some of the things you got to be wary of when obviously putting these in. This is the MRI that he came to me with from his, family medicine doctor that saw him in post-op. The surgeon had changed practices like 2 weeks after they did the surgery. So the patient ended up coming down to see me. So yeah, not too helpful. It's hard to determine whether there's still some stenosis or that's metal artifact. I think there's something there. So we get a CT myelogram. Hopefully that's projecting okay. You can see specifically at C3, C4 that there's still some continued central stenosis there. You got some loss of the CSF signal both in front and behind. And you can see here there's still some cord flattening there, especially on the left side, and still osteophyte there. Not too bad stenosis, but just some anterior effacement there. When we took him back, we did a corpectomy. We talked to him whether ACDF would be the right option. The bone was actually very soft too. Over the course of even the month that he had, his bone had softened. And we got an MRI at 6 months post-op. He had some worsened neck pain after a fall, and we ended up getting an MRI, but you could see his decompression is good. We have 3 more minutes here, so we'll do one more case. There's a patient that came to me about 1.5 years after surgery. Initially, she did have a lot of neck pain right after surgery, but that improved. But here's her MRI pre-op. You can see she has stenosis, myelopathy symptoms. She had this. This is the intra-op x-rays done. There's no pre-op x-rays or CT scan. You can see here maybe just from the positioning, there's a little bit of a coronal deformity, but it's kind of hard to tell, but this is sort of the extent of the x-rays that we had. And this is the initial post-op. You can see she still has her gown on. You can have the disc replacement. There's a little coronal deformity here, maybe a little bit undersized. The bottom disc you can see here is there's a little bit of a mismatch between the top and the bottom of the device implant when it was put in. So this is about 3 months later. You can see that it's having some continued deformity, some continued anterior, some kyphosis that's happening. And she ultimately moved. Her family had to come over through the military. They had to move. She was actually doing okay with some neck pain, but started developing arm pain after going on vacation with her kids. And apparently they were doing some rough housing in the swimming pool and ended up having worsened pain and came to see me and having arm pain. So ultimately we got more imaging. You can see it's not been progressively worsening, but still there, and some increased motion. That's probably not the way the device is supposed to function. And you can see here, there's the MRI that we got. A lot of artifact there. And this is the CT myelogram here. I looked at the frame, and it's hard to tell for me on the CT myelograms. They're not really good for foraminal stenosis unless there are osteophytes out there, but not too much foraminal stenosis, overall mild. So this is what we did. We did a 2-level ACDF. I got this x-ray post-op, and I was not happy. I mean, she still has this coronal deformity. During surgery, we got her intra-op x-rays. Everything was nice and straight, and was kind of confused, but gave it some time. You can see over time she straightened out. So I don't know if it was just some kind of pain thing where she was having some increased pain, but ultimately she straightened out. So those are my 2 cases. I won't go to the last case, or I could just show you quickly, but he developed HO. I think we went over these cases, and we ended up doing a corpectomy. This is an old ST device. Thank you.
Thanks, Dan. That was a terrific overview. One question for you is for a failed, painful total disc, say a single level total disc. that you want to convert to a fusion is posterior only an option. And the idea being that the implant, although most of these implants change in sagittal angulation at that segment, are typically considered kind of length stable in the anterior column. So can you just lock them down with pedicle screws or lateral mass screws and expect a fusion? Is that a reasonable option?
Yeah, I think so. Yeah, someone who has you've seen the patient. I showed you a patient where were really distracted. We understand better now that we shouldn't oversize these things, but in the past, we kind of oversized them a little bit. But I think in that case specifically, you could probably go to the back, and if you can and they have a flexible deformity, you can kind of crank them back, and maybe not too much neurologic symptoms or foraminal stenosis that you need to take care of, but you can still get fixation around that. Yeah. But I think it's a good option. There's also some patients where you don't want to go back to the front again. Right. That's pretty rare for a 1 or 2 level disc replacement that you've done, but someone who has some really severe dysphagia post-op, or somebody you find has a recurrent laryngeal nerve palsy after surgery. And interestingly, that patient that I showed with the 2 level that just had the 2 level, she had a recurrent laryngeal palsy, so I had to go from the right side. Yeah. Or sorry, same side. Yep. Yeah. Thank you so much.